Welcome to the Greater Winter Haven Chamber of Commerce Ask the Doctor series. This series is done in partnership with Baycare's Winter Haven Hospital to provide you, the community, an opportunity to get to know our local physicians, as well as the many important services and programs that Winter Haven Hospital provides to keep our community healthy and thriving. In honor of Heart Month, we get the chance to speak with Dr. David Dodd. Dr. Dodd is board certified in thoracic surgery and vascular surgery. Dr. Dodd tells us about his position as the medical director for the structural heart program at Bostick Heart Center at Winter Haven Hospital. He also shares how he came to Winter Haven and the different treatment options available for his patients. Well, thank you, Dr. Dodd, for being on the show. We're so excited to have you.
Thank you for having me and taking the time to do this. I think it's important to get information out in the hands of the community.
Absolutely. And this is one of the ways that we like to do that. So we like to, give the local community a chance to get to know our local physicians. So Baycare is a big part of that. And usually we like to start the interviews with you telling us just a little bit about yourself. So how did you come to Winter Haven, a little bit of your educational background, and anything else you want to share?
Okay. I grew up in Atlanta, Georgia, and went to college and medical school at Emory University, and then moved to Memphis, Tennessee, and did my training in general and vascular surgery at the University of Tennessee. And I practiced general and vascular surgery for 3 years, but really wasn't a satisfying practice to me. And I went back to do cardiothoracic surgery, and then spent another 7 years there doing that before we moved to South Georgia for about 5 years. We had small children at the time, and I was not home a lot.
Mm-hmm.
And so we were really sort of looking for a little bit of a change of pace. This flyer came across my desk, and actually it was from the Christian Medical and Dental Association. And I usually just threw all of those things away, any of the headhunter kind of mail.
Right.
But for some reason, I looked at this, and they said they were looking actually for a vascular surgeon in Winter Haven. And I told my wife, I said, maybe that's what we need to do, and we will have some semblance of a reasonable family life. And came down here, and they were looking for a heart surgeon, and David Evans was in the process of moving here, and so we moved here in 2006 and started working there. So I've been at Winter Haven Hospital since 2006 for 16 years.
Oh,
and
wow.
been a part of Baycare now for the past almost 7 years.
Okay, great. What has your experience been like kind of with this area in comparison to being in Georgia to here?
It's been great. It's a little more metropolitan than the community we lived in South Georgia. It's not anything like Atlanta, but the traffic there is so horrible that I don't miss that. I still have a sister that lives there, but that we actually live in Lakeland.
Okay.
But we can get the commute here is very easy, and we have the benefits of being able to go to a larger city for sports events or social events and concerts and things like that in either Orlando or Tampa. So it's a great place to live. I think it's been a great place to raise kids. We're finally empty nesters almost now.
Nice. Well, congratulations.
So. Yeah, it's been great. I've never been more certain that I was where I was supposed to be doing what I'm doing than when we moved here.
Well, that's great to hear. And I think there are a lot of great benefits to living here in Winter Haven. It's a great location, and it still has that metropolitan vibe without the crazy traffic of those metropolitan areas.
Absolutely.
So I wanted to ask you too, a little bit about your role at Winter Haven Hospital and what that looks like on a day-to-day basis.
So when David Evans and I came here, there was not an open heart surgery program. They were in the process of organizing that. So we started it here with the Ocala Heart Institute. And we were doing cardiac surgery, non-cardiac surgery, such as lung surgery or so forth, and then some vascular surgery as well. Um, and we've been the only two surgeons here for the bulk of that time. A few years ago, there was a great interest in starting a structural heart program, which we can talk about a little bit in a minute if you want.
Sure.
But
Absolutely.
basically, it's a minimally invasive way of treating valvular heart disease, and it's a multidisciplinary team that we use to approach these patients. And so I was asked to head that up with the help of the interventional cardiologist. And so my role now is still to do primarily cardiac surgery, but we have a very busy valve clinic uh,
Mhm.
that we see a lot of patients in. And then we have a team that meets actually every Thursday to discuss potential candidates for these minimally invasive procedures. And so it's a pretty involved process, uh,
Okay.
but we've managed to our volume's been pretty steady, and we've had a good run so far.
Well, do you want to tell us a little bit more about what that program looks like?
Sure. So the primary, I guess the most common procedure that we do is called a TAVR or TAVI, which stands for transaortic valve insertion or transaortic valve replacement. And what that is it's technology that's been developed where we can replace a valve by inserting a catheter, usually through the femoral artery in the groin. And the benefit for that is that we avoid a sternotomy, an open chest incision, and we avoid some of the morbidity and mortality that's
Mhm.
associated with open heart surgery. And the technology was originally developed for patients that we didn't feel we could get through an open heart procedure. So these were unfortunate patients that, because of comorbidities or other pardon me, other um, medical issues, we just didn't feel like were good candidates for open heart surgery. And before this technology was available, they were relegated to a life of being short of breath and in heart failure.
Mhm.
Somebody a lot smarter than I am figured out a way to compress these valves and put them on a catheter. And so now that's the way we place the valves. It's an operation that's done in conjunction with a cardiac surgeon
Mhm.
and an interventional cardiologist. Um, but the vetting process, if you will, is pretty extensive. These patients have to have a heart catheterization, they have to have an echocardiogram, and they have to have a very specialized CAT scan or CT scan of the chest to make sure that they're good candidates for that. Once
Right.
we get all that information, we then present them to a multidisciplinary conference. And it's usually about a dozen guys sitting around the table. And we look at all that information and, through a shared decision-making process, try to come up with a treatment plan that's individualized for each patient. Um, we started the program in March of 2020 in the middle of a pandemic,
Oh, wow.
which was crazy, but we were very careful about what we did and our patient selection, and it's been very successful. Our results have been very good, and it's continuing to grow. We also treat patients with mitral valve disease, mitral insufficiency, with a device called the MitraClip. That part of the program has been a little slower to develop. Those patients are not quite as common as the aortic valve patients,
Mhm.
but it's also a way of treating a problem that doesn't always do well with open heart surgery. And the goal with that particular type of therapy is to keep those patients out of heart failure and ultimately out of the hospital.
Right.
So my role as director of that has kind of been to, you know, sometimes it feels like I'm herding feral cats,
I bet, I bet.
but it's to coordinate the efforts of the interventional cardiologist and the surgeons, my partners, the echocardiographers, the interventional radiologist, or excuse me, the radiologists and the CT scan techs and so forth, to gather all this information, and then to make sure that what we're doing is the right thing, and that we're not, we're not falling into that trap of to a man with a hammer, everything looks like a nail. kind of
Right.
mentality. So.
Yeah. I wanted to ask too, so is the recovery different between, open heart surgery to this, more specialized surgery? Is the recovery time different for that?
It's very, very different. One of the one of the things that's been we've had to kind of remind people of is that when we see these patients, so we get asked to evaluate a patient with aortic stenosis, for instance. Uh, if we're considering them for open heart surgery, the run up to that is fairly compressed. It's fairly short. It's usually a heart catheterization and an echo. If they're in the hospital, they usually get operated on before they go home. Then there's about a 6 to 8 week recovery period after a open chest, open heart
Mhm.
procedure. Um, with the TAVIs, the run up to the procedure is much longer. We've gotten it down to about 30 days, but we have to coordinate a catheterization and the CT scan and all these tests.
Mhm.
Once we do the procedure, they come in the day of, have it done. The next morning, we check another echocardiogram, and most all of them go home that day. And
Oh,
they
wow.
could literally be back doing whatever it was they were doing before they came into the hospital within a day or two.
Wow. That's incredible.
So it's a very different approach, but it's been very successful. The problem that we run into with that particular technology is everybody wants one, and not everybody
I bet.
is a reasonable candidate for it. So.
Right, right. Well, I'm sure that those qualifications also help them. I mean, you want to be mindful of who use for those surgeries, because I'm sure there's a lot that goes into that for, qualifying for that type of a procedure.
Very much.
So what are some of those common symptoms that people would come into your clinic for?
So we still see a vast number of, I'd say the majority of our patients come in that have coronary disease, symptomatic coronary disease.
Mhm.
Because we've started this program here, though, we have seen a marked increase in the number of patients that have valvular heart disease referred to our clinic. So typically, a patient with coronary disease, for example, would come in with a history of some type of exertional angina or exertional chest pain, or maybe even some shortness of breath as they exert themselves. Um, Usually, they've had a stress test and/or a heart catheterization, so we know what their anatomy is when they come to see us.
Mhm.
With valvular disease, the symptoms can be a little more insidious, and slow to ramp up, so to speak. But they typically will present with a history of fatigue, of diminishing exercise capacity, with some shortness of breath, sometimes even with some chest pain or palpitations. And occasionally we've seen patients referred to us that have actually had a syncopal episode where they've actually passed out.
Oh,
Uh,
wow.
but so it's more heart failure type symptoms when they've got symptomatic aortic or mitral valve disease. Whereas with coronary disease, it's more chest pain and discomfort kind of symptoms.
Okay. And what are some of the treatment options that you guys offer at the clinic?
So in our clinic, it's pretty much surgery, which
Okay.
as I told somebody that just this morning in the office, I've been doing this for almost 30 years. I've never had a patient come in and say, I was thinking it would be fun to have heart surgery next week.
Yeah,
Uh,
probably not.
but no one ever. Um, as far as the coronary bypass surgery, it's pretty much bypass surgery. Now, we will occasionally look at some of these films and look at the patients and say, you know what, we would like to get some input from our interventional cardiologists. These are typically patients that have been referred from outside
Right.
the local area. And we have such good interventional cardiologists here at the hospital that I have no qualms about asking them to look at a patient and see whether they be, if perhaps uh, a stent and angioplasty and stent would be a more appropriate therapy.
Mm.
As far as what we offer somebody with coronary disease, it's coronary bypass surgery. As far as the valvular disease goes, we look at these patients and try to decide what's the best treatment. And a lot of what goes into that decision making is their age at the time they present. Uh, we don't typically want to recommend a TAVI or a minimally invasive aortic valve to a young patient, because we know they're going to outlive that valve, because it is a tissue valve and there's a lifespan on that valve. So if we see a particularly a younger patient, we'll talk to them uh, uh, openly and honestly about the choice of valve, but we really try to push them toward or win them to the notion that they need open heart surgery rather than a minimally invasive approach at this time.
Right.
If they're young enough, then we really like to put a mechanical valve in, but that does require anticoagulation, lifelong anticoagulation with a blood thinner. In patients that are a little older, but still not in their 80s, and they're, I'd say the 65 to 75 range, will if they are insistent, we'll we'll talk to them about a tissue valve, recognizing that down the road we can put a TAVR valve inside of that tissue valve if and when it wears out. But by and large, all the tissue valves that we use have a limited life expectancy of
Mhm.
about 10 to 12 years.
Well, it's good that you guys are always looking into the future, obviously, because you don't, you want it to last a long time and not affect them down the road. So,
Yeah, I think one of the things that's important for them that we try to help them understand is that when we have a conversation with them about their heart disease, we're talking about what's going to be the plan for their lifelong care, particularly in the younger patients, that recognize that they're going to need more than one procedure. And so let's try to figure out, what's the most efficient way and safest way to do that.
right,
And it's individualized for every patient, of course.
right. And how would someone who's listening or watching be able to come and see you? What's some of your information, where you're located, and all that good stuff?
So our office is in the Bostick Heart Center. If you pull into the main parking lot of the hospital, you'll see the main entrance, and I always get the directions messed up.
Hey, that's okay. That's okay.
Just to the north of that
Gotcha.
um, uh, entrance, you'll see a right. It's actually part of the building where the emergency room is. You'll see a sign that says the Bostick Heart Center on there.
Okay.
And so you can actually go straight in there and come up to the third floor, and our office is there. Um, as far as patients coming in to see us, most of them are referred
Okay.
with the uh, regulations and the constraints now on patient referral. They're usually their primary care physician or a cardiologist has to get an approval for a referral to see us.
Okay.
We see patients 4 days a week. We usually see them in between uh, operating in the operating room. So we're here. We've got 3 outstanding PAs and an APRN that work with us very closely, as well as a valve clinic coordinator. Um, and our PAs in particular have heard the spiels we give patients so many times they can repeat them in their sleep. But they're very knowledgeable, very helpful, and I would tell you that probably half our patients think that they're our partners, not our PAs. So
Nice. Well, that's good. That's a great welcoming environment then.
yep.
Well, good. Is there anything else that you want to share, Dr. Dodd?
Uh, no, I'm going to steal a marketing phrase from a place where I used to work because I really believe that it's true. Um, but there was a hospital where I worked in South Georgia, but they used to say this is world-class care with a hometown feel. And I would say that's a lot of what I see here at Winter Haven. We've got really good subspecialists here to help us, care for these patients. We've got an outstanding team in our office and also in the operating room and the intensive care unit. And it's been, I've had the opportunity to work in a lot of ICUs and a lot of ORs, and I've never been in one that was um, as cohesive, and caring as this one. The people that work here, um, they don't just care about the patients, but they care about each other. They look out for each other, and you don't find that everywhere. So I think it's been they're a lot of the reason why I keep keep doing this.
Absolutely.
They've been a tremendous blessing to the whole process.
Well, I think that makes a huge difference when it comes to, the experience of the patient, making sure that, you guys are cohesive and working together. So that's really encouraging, I'm sure, to everybody watching and listening that, Baycare and Winter Haven Hospital, they have a good thing going. And we all know that. So thank you so much for taking the time to chat with me.
Well, you're very welcome, and thanks for all you do for getting this information out to the community. Because again, I think it's very important. They've got a choice about where they go for their health care. So I think it's important that they know what they've got here in their own backyard.